Good morning, and sorry for being late. We've had some last-minute technical difficulties. My internet connection went out at just the wrong time, so I had to call in via telephone, but hopefully you can all hear me, so we apologize for the delay. Welcome, in any case, to the Peter G. Peterson Foundation Economic Forum. The purpose of our forum is to bring together thought leaders for in-depth conversations on America's most pressing economic issues. Our initial series in the forum is focused on the COVID-19 pandemic, exploring lessons learned, ideas for reopening the economy, and how effective fiscal policy can both aid the recovery and prepare us better for the next crisis. So we kicked off this forum with a session in June with CBO Director Phil Swagel. He talked to us about a range of enormous economic and fiscal policy matters that CBO is focused on. Today's second session of the forum is called The U.S. Healthcare System, Preparedness, Response, and Future Trends. I'd like to focus the conversation today on what we can learn from the COVID-19 situation. From a health perspective, as we all know too well, COVID has killed nearly 180,000 of our fellow citizens. From an economic and fiscal standpoint, it's perhaps the most complex policy challenge that we've ever seen. This crisis has left tens of millions out of work and led to trillions and counting in legislative support. From a healthcare sector standpoint, this pandemic has exposed a range of shortcomings. Clearly, we lacked preparedness in a number of critical areas heading into the crisis, from the availability of supplies to the lack of a coherent national strategy. At the same time, there are ongoing endemic issues of racial injustice that persist in our society that have been revealed, once again, as communities of color are disproportionately affected by both the health and economic effects of COVID-19. On the positive side, we have both an opportunity and a responsibility to explore ways to learn from this crisis to build a more effective healthcare system. For example, the widespread use of telemedicine out of necessity represents, in our view, a real opportunity going forward to improve access to care, the cost of such access, as well as the convenience and quality of service to patients. So for this important conversation, I'm very delighted to welcome two distinguished guests. We have first Dr. Michelle Williams. She's Dean at the Harvard T.H. Chan School of Public Health. She's a distinguished professor and clinician whose research has greatly advanced the study of reproductive and perinatal epidemiology. Dr. Williams has worked extensively in developing the multidisciplinary international research training program, for which she was awarded the Presidential Award of Excellence from the National Science Foundation. We also have with us today Dr. Harvey Feinberg. He's president of the Gordon and Betty Moore Foundation. Previously, Dr. Feinberg led the Institute of Medicine from 2002 to 2014 and was also dean of the Harvard School of Public Health. As the chair of the Standing Committee on Emerging Infectious Diseases and 21st Century Health Threats at the National Academies of Science, Dr. Feinberg has played an important role in advising the federal government on its response to the pandemic. And while Harvey has had a lot of great titles, I know his most beloved role is as chairman of the advisory board of the Peterson Center on Healthcare. We've been so lucky to have your input, Harvey, and guidance toward our mission to improve healthcare delivery in the United States. So let's bring them on and begin the discussion. Good morning. At least they can see the two important people here. So hopefully your internet continues. So welcome and thank you so much for being with us today. So let's start with America's preparedness and response. And I'd like to keep the conversation as best we can, at least within the healthcare system itself. There's so much to talk about on COVID, from the policy response and what's going on in states and so forth. But let's try to focus the conversation within the healthcare system so we can understand what's going on there. As you well know, the U.S. spends twice as much on healthcare as other industrialized nations, yet I think we all would agree our hospitals and healthcare systems were largely unprepared to deal with this pandemic. And I think, as discussed, there's a range of positive lessons and negative lessons to take from this. So let's start with the failures. Harvey, let's start with you, but I'd like to hear from both of you on what are our most urgent system failures that were revealed in this crisis. And if you could look at it maybe in three different contexts. One, before the crisis, so heading into it, what should we have been doing as a nation to be prepared and increase preparedness for the unexpected? Two, during the crisis so far, like what's been going on in terms of how you view the response and what have we learned about our shortcomings? And then importantly, going forward for the next year or longer until this is resolved, what do you think are the most important priorities? So Harvey, why don't we begin with you and then hear from Michelle.
Well, Michael, thank you so much. I am delighted to be with you, and it's a special pleasure to be with you and with my beloved colleague, Michelle Williams. I really look forward to the interaction with her and with you in the course of our time together. When it comes to preparedness, it comes at multiple levels. The US had many, many warnings about pandemics. We had the experience of the 2009 H1N1. We had overseas the Ebola experience. We had many ways in which we could recognize the demands that could be placed on our health and public health systems from a widespread pandemic. I would say most of those underestimated the importance of coronavirus, even with SARS and MERS as the background, compared to influenza, which, by the way, could still be the source of another critical global pandemic. But the idea that pandemics would occur, that they do occur periodically from emerging disease, was not a new or unfamiliar idea. Plans were laid. There were many discussions about preparedness at the national level, at state levels, at local levels. We did not, however, implement the necessary background preparedness that those plans called for. For example, we failed to put into place the number of ventilators that the plans called for in a national stockpile. There were some half-hearted efforts to do it. They didn't quite work out along the way, and it just fell by the wayside. We disbanded a part of our national security infrastructure that was specifically concerned with the future pandemics. So there was no high-level continued attention to that background readiness. And we paid a price for the inability to respond directly and immediately. We also suffered from a number of shortcomings in our strategic response in the beginning and in some ways continuing. We never really established a unified command structure, the first principle of any military strategy, in which there is a clear national strategic plan and someone in charge, not simply coordinating across, but responsible for executing across the board. We also have not had consistency in communication. There's been a continued ambivalence about the pandemic. Is it real? Is it going to dissolve on its own? How important is it? How significant are the strategies of wearing face masks? I remember well my first conversation with Dr. Gao, the head of the China CDC, and I asked him after the outbreak occurred in China, I said, what advice would you have for the United States? And he said, everybody should be wearing a face mask. And he said that back in late January, February of this year. So we haven't executed at that level. And I'll just make one other point, Michael, on the systemic exposure that this pandemic has revealed. We depend predominantly in our country on employer-based health insurance. When millions of people lose their jobs, that means millions of people are losing their health insurance. And when that economic crisis is caused by an illness, a disease, it's a double hit, because just when more and more people need medical care, more and more are losing their health insurance coverage. So that revealed another systemic challenge. And finally, I'll just say, when it comes to the racial disparities, COVID did not create the disparities. COVID exposed, exacerbated, and revealed how important disparities across different racial groups are for health, for economic well-being, for belonging in society. And that's been another very profound lesson of preparedness.
Thank you, Harvey. Michelle?
Michael, first of all, thank you for inviting me to be a part of this conversation. You might not know this, but I entered public health as a student in 1986, and Harvey Feinberg was my dean. And so it's a great honor to be involved in this conversation with my dean and now my great colleague and friend, Harvey. And he's just done a
Wow, I didn't
masterful.
know that. Nice job, Harvey. You did pretty well with this student.
I sure
Uh,
did. And I, of course, take full credit for all of Michelle's achievements since 1986.
but I think Harvey's just done a masterful job responding to your question, and I just want to take a moment and underscore a few particular points. First, with response to preparedness. Um, one of the things that we learned painfully is the lack of real leadership and commitment to being prepared, because it was never a question of if we were going to be faced with a pandemic, it was when. And an explicit example of our failure to really be positioned and prepared for this challenge that we now face with COVID-19 is that after the H1N1 crisis, we did not, as a nation, work to replenish our supplies of personal protective equipment. And that's just one concrete example of the missed opportunity that we had as a nation to really position ourselves to protect and promote the safety and wellness of our frontline health workers, for example. And so that's an example of a disheartening response to a pandemic that we knew would happen, and we missed that opportunity. I would say the other disheartening feature that is unfolding right before us, and Harvey alluded to this, is that the pandemic lays bare the inequalities that still exist in our society that drive health disparities. And one really particularly disheartening observation was that as we were beginning to mount a response, albeit late, there were large swaths of our communities that were not necessarily receiving a timely response in terms of just testing. So, as many of us were heeding public health interventions to work remotely and to disengage in our activities that might be driving community spread of the virus, members of our Black and Brown and low income communities did not have that option. And compounded with that was the fact that they didn't have access to testing. And many communities still don't have access to efficient, timely testing so that decisions can be made to protect and preserve our health, wellness, and our workforce. And thirdly, going forward, we have lots of lessons learned here, but one of the key lessons I think learned from our failures, where we can learn from these failures, is that public health can no longer be undervalued, under-resourced, and should never be pushed aside or be siloed. I think we're all recognizing and reckoning with the fact that public health is intertwined in every aspect of our civil society, our economic security, our national security. And we should not go back to a place where public health is regarded as a siloed operation, but as an operation, as a discipline, as a practice and an approach that is central, that is intimately intertwined in every aspect of our national security, our economic security, and our capacity to have our full population thrive and grow.
Thank you. Let me follow up with you on some of those issues. So, in terms of the disparities and the disproportionate impact on communities of color, what sort of policy interventions would have the most impact on addressing those disparities? And do you think the greater level of awareness and the widespread movement for what racial justice that's going on right now, and the impact of this disease and the visibility of it, do you think that could help lead towards greater and faster positive change within the health system in these areas?
Michael, I think there are real opportunities here to capture the moment. This is a moment when there is increased awareness across all sectors of the primacy and importance of public health, the primacy and importance of prevention, and building institutions that support a social safety net where health and wellness are promoted. I think when you evaluate the extent to which this pandemic brought us all to our knees, we have an opportunity to work across all sectors, the private sector, the public sector, the academic sector, and the philanthropic non-government organization community to think about the approaches we have to take and reinvest in building a more equitable and just society. Access to healthcare, the Affordable Care Act did a lot to close some of the healthcare gaps, access to healthcare gaps for millions of Americans. That's one very important policy that actually is a down payment on improving healthcare and promotion of health and wellness for all. But it's not just about access. We have to also look at healthcare quality. And so policies and programs that promote, support, and enhance improvement in healthcare quality are going to be critically important for driving down those factors that contribute to high rates of chronic diseases, respiratory disease, diabetes, hypertension, that place individuals, particularly Black and Brown people, at high risks for mortality due to COVID. The business sector has a very important role to play here because they have now recognized the importance of not only modeling financial risks, but recognizing that having access and a capacity to look at risk mitigation and risk assessment through a public health lens can help to do two things: protect, preserve, and ensure that the workforce is available and present to contribute to society across sectors, but also that they have the important information and the framing to persuade, encourage, and promote the consumer, the population writ large, of the readiness and the approaches taken to protect and promote re-engagement in economic activity. I think because there is now an increased awareness to how interconnected we all are and how valuable an investment to promotion and disease prevention is to undergirding our society, we should be in a position to take this moment of awareness and build it into, going forward, a movement that values, supports, and enables public health systems to thrive.
Thank you. Harvey, Michelle mentioned philanthropy. Obviously, you had now a large foundation. How do you see the role of philanthropy in this crisis, in improving our preparedness, in addressing some of these inequities in the system, not just within the Moore Foundation, but across the sector?
Thinking broadly, Michael, for the whole sector of philanthropy, there are a multiplicity of ways that foundations and private individuals, out of their own philanthropic generosity, can contribute in both the near and longer terms. At the one extreme, we have foundations of the scale of a Gates Foundation or a Wellcome Trust in the United Kingdom that are central players in the development of vaccines, the distribution of preventives around the world, and really crucial partners to governments in all parts of the world to help bring protection more rapidly to people everywhere. At the other extreme, we have local foundations, community-based foundations, where they have chosen to pay special attention to the needs of nonprofit organizations that, in the face of COVID, are suffering enormously in their ability to persevere and provide the services that they provide to their public. They may lose revenues, they may have inability to conduct their work in the usual way because of COVID, They may have setbacks in terms of direct access to the clientele and populations that they are working with. In between those two extremes, you have a wide spectrum of philanthropic interest and commitment in areas that bear both directly and indirectly on COVID. For example, there's a group of foundations called the Science Philanthropy Alliance that has undertaken individually and through some cooperative action concrete investment in certain scientific advances in therapeutics, diagnostics, and preventives that are not yet on the government radar screen. Philanthropy as a field has the agility, the speed, the flexibility, the adaptability to be able to move into places and onto problems before and beside where government support is moving. Foundations is distinct from government or even businesses in terms of business related investment in research. Foundations do not have constituents in the same way as a government, and we don't have shareholders in the same way as a business. And so philanthropy has this distinctive role. And I might add, especially in the US system, where over decades we have encouraged and supported the development of private foundations, encouraging through our tax laws and in other ways individuals whose own economic success they wish to translate into broader social good. So philanthropy has a very important role to supplement, augment, and sometimes to lead, aside from what government and industry and the academic world do to advance on a problem like COVID.
Michael, if I may, I completely agree and want to give another example. Very early on in the unfolding of this pandemic, it became very clear that our frontline health workers were going to really be in harm's way, the path, of this oncoming tsunami. And it was through collaborating with foundations who can be quite nimble and can aggregate players and partners from multiple sectors in a very fast way. It was through foundation support that we in academia and our colleagues in the tech industry were able to come together, raise funds, but also then deploy the funds through a network of implementation partners to provide healthy meals, safe housing, and childcare for first responders who were being challenged not only by the physical and mental toll of their work, but had to manage their family responsibilities, manage the risk of their bringing COVID into their household with vulnerable elderly population or young population, and not being well prepared for self-care during what is unfolding as a marathon of a response. And, as an academic leader, I had the privilege of partnering with philanthropic members of the philanthropy sector, as well as the business sector, where we were able to mobilize resources, pool our assets in a way that could bring timely solution to an ever-unfolding and complex problem. And so there are definitely roles in leadership, in mobilizing resources and talent that I have borne witness to, where the philanthropic community has very well contributed to solutions.
And I might add that Michelle's point emphasizes the role that academic leaders can play through universities as thought leaders, as also advisors, to bring together important players across all sectors, from business, from government, and from philanthropy, to forge practical and immediate solutions. And that's a very important part of the ecosystem of problem solving in the United States. Our academic community, our business community, our public sector, and our philanthropic sector working in concert to solve people's problems.
Well, there's a lot more to do, and we all need to come together to solve these challenges. You're absolutely right. I've got some more questions, but I just wanted to remind our audience that we'd love to hear from them and hear any questions they have for our two distinguished speakers today. If you click on the question mark at the bottom of your screen, you could submit your questions, and I can take them. I want to talk about what's going on that's good, okay? And it may be hard to do that, but I think it's important to, again, have some positive lessons coming out of this. COVID-19 has sped up the adoption of a range of technologies. We're using one today, obviously, in this difficult situation. But as I mentioned before, telemedicine has been on the rise significantly. Contact tracing and data gathering, global information sharing. There are certain things going on out of necessity and within this emergency that we may want to actually use to leverage to continue to improve the system. So what are on your list of the most positive things going on that you think we should be promoting and fostering for the future? So Michelle or Harvey or both of you, whoever wants to go first.
Well, there are some positive developments. One of them I alluded to early on, that the increased awareness and understanding of the importance of public health and how central investment in disease prevention, health promotion, and wellness for all is really being embraced and seen in ways that it had never been seen before. I think there's also, just from a provincial academic perspective, the fact that people can actually pronounce the word epidemiologist, and journalists and others are coming to public health, and people are recognizing and seeing the value of public health, the value of investing in promotion of health and disease prevention, are very big positive things. And I think we have an obligation to turn this moment into a movement. The advances that we've seen made in the delivery of healthcare using telemedicine, and the reforms that have been put in place as a response of this emergency in paying appropriate compensation for delivering telemedicine using the technology platform is promising. And I would hope that we would not dial back those advances as we make our way out of the pandemic, but that we really learn from these natural experiments where we've implemented telemedicine platforms in places to fill gaps. Even before COVID, we've had huge disparities and huge under availability of access to quality medical care in some of our rural communities, and particularly in the area of behavioral health and mental health, where the needs were great in communities that have very small numbers per capita of qualified psychologists and psychiatrists. Telemedicine and technology is an important potential platform that we are learning how to leverage, how we can then expand access to quality care to individuals in areas that don't have resident medical expertise. So I see that as a positive. I also see the positive as the increasing recognition of just how important it is to invest and support a social safety net that has over decades have become quite threadbare. And by that I mean investment in interconnected services and social platforms that enable quality housing, quality education, the awareness that we do have to pay attention to place-based interventions that holistically address barriers to economic development, educational and employment opportunities in communities that have been left aside. One last thing I'll say, and it's the increased awareness that we still have a lot to do in terms of cleaning up our environment. Just a week ago, I participated in a conversation in Detroit where there are still communities, census tract areas, where 80% of children have lead levels well above the CDC guideline. This is the 21st century. The fact that we still have children who are suffering generational attenuation of their development because of a century-old problem of lead in our environment. Having the awareness and the social and political will to address this is something that I think will grow out of the lessons learned. One last thing, increased communication about the science, the importance of evidence, and the importance of increasing health literacy, I think will be a lasting positive outcome, because we do have to work on reinforcing and supporting a more science-forward, evidence-based population where decisions are made based on science and not on the false dichotomy of the choice of health versus political liberty or economic security. They are both and types of choices that we need to make. And I think our population are engaged in a way that they can see and appreciate the importance of rebuilding in a stronger, more holistic approach.
Thank you. I have one follow-up from an audience member. Susan Brown asks, is there a risk that systemic racism will adversely impact services like telehealth? I think telehealth does expand access and so forth, but I think she's asking what are the ways that systemic racism may adversely impact that opportunity, or what are the issues within that may occur?
Very briefly, I think the fact that we have large areas of the U.S. that does not have broadband access is what this individual is referring to. If we push forward a telehealth solution without also understanding that there are communities that don't have access to broadband technologies, then it will accentuate disparities. When we bring about new tools and new interventions, we really do have to think about what are the structural, social, political, environmental barriers that might attenuate the access to these new tools, new capabilities. And one of them really is a historical lack of investment in some of our infrastructure across the rural parts of our country. So it is possible, if we're not attentive to the disproportionate access to broadband, that we could be accentuating health disparities by not addressing that foundational infrastructure issue.
Mm-hmm. Michael, if I could comment on that.
Someone from the Peterson Foundation might say to that, one of the important reasons to get our fiscal situation under control is to enable us the ability to afford important investments in our future, and spending $1 billion a day on interest doesn't make infrastructure any easier, that's for sure. Harvey, what are your thoughts on what's going on that you'd like to see continue or be replicated?
Well, thank you, Michael. First, I was going to extend this point on the infrastructure because sure. I do think that there's a positive side to that questioner's query about could it exacerbate disparities if we make the kind of investments that Michelle is talking about. We have an opportunity to reduce a barrier that would otherwise stand between the access of individuals to high quality care. In the same way that President Eisenhower invested in the infrastructure for our national highway system, or rural electrification in the 1930s under President Roosevelt, these were the kinds of infrastructure investments that radically leveled a playing field, made accessible services and quality of life that were unattainable. And when you think about the importance of a internet connectivity and an infrastructure that supports it for education, for work, for entertainment, for life, you can see that it is an exact analog, in my mind, to those substantial national investments that knit the nation together in a more complete and a more inclusive way. And that is the reason those investments matter. From the point of view of a longer term, Michelle spoke very eloquently to the health and patient care elements, including the telehealth that you've mentioned, perhaps also around hospital efficiencies and management, because keep in mind, hospitals are under enormous financial stress during this time when they're unable to care as frequently for other patients and have COVID patients to deal with. But more broadly, I wanted to just say a word about adaptations in business and in the nonprofit sector in our lives of work that COVID has introduced. It has separated many people from the workplace. So the idea of productive work and the idea of being present in a physical location are no longer as synonymous with one another as they used to be. And rather than taking for granted that work means showing up and being in the same place at the same time as your colleagues, the COVID experience is bringing every business to the question of when and why does it matter that our colleagues are together. And so you think about the conduct of your business and the achievement of your business goals in a way that doesn't presume that physical presence in a uniform way, but is now forced through the experiment imposed on all of us by COVID to re-ask the question, when does it matter that we're together? And when can it be as good or perhaps better to liberate individuals, give them the flexibility, allow them the opportunity to work from a remote location? So this is a big change in business, and it's coupled with the impact on decisions about travel, the nature of business gatherings, the nature of convocations, how much in person, how much can be done successfully in a remote way. These questions are going to be taken for our country over a long period of time to answer, far longer than the COVID pandemic. I don't believe we're simply going to throw a switch one day and return to life, work, education exactly the way it was before the COVID pandemic. This experience is opening our eyes to the burdens and the possibilities of conducting education, our businesses, our daily interactions in ways that are different than we did before, possibly more effective, possibly more efficient, possibly more satisfying, and in the end, more productive. So these are going to be some of the lasting impact on a positive sense that I think will come out of the COVID forced experience.
Michael, if I may, I just want to really
Yeah, go ahead.
underscore what you just said, because I think what comes out of this is our redoubling of our effort and our commitment to a human-centered design that touches every aspect of our lives. And I would just add that this is particularly important now because as we realize that our healthcare and caregiving workforce is shouldering so much of the everyday immediate stress of taking care of patients, taking care of our elderly. As we go forward, what comes out of this is our awareness of needing to be attentive to the designs that we have in place to support our thriving as a society. And this is particularly true for caregivers who are so much under stress even before COVID, with issues of burnout, with issues of stress and anxiety. And so we have a real opportunity here to take the lessons learned and redesign the way we live and work and learn in this society.
Thank you. We're running a bit over, but there's a couple more good questions. So if people are able to stay on, we'd appreciate going a bit over. I have a question from Leonard Levy. We're all thinking a lot about our institutions. He asks, should we legislate changes that better insulate institutions like the FDA and CDC in a model like the Fed? What do you think of that issue and their level of independence, and is that something we need to pay attention to?
I'll offer a view. Personally, I don't think legislation is the answer to this question. I think you can end up excessively separating institutions that ought to be an integral part of our total healthcare national system under the direction of the Health and Human Services Secretary. So I don't think it's a structural problem. What really matters is that the scientific integrity, the sense of responsibility for the professionals that run these agencies and populate the key positions be a matter that is respected and valued by all of us, because we depend on their independent, scientifically informed, and public spirited conclusions, guidance, and advice in order to make smart decisions for ourselves. So protecting their scientific integrity is a matter of policy and practice more than it could be, in my mind, a matter of legislative insulation.
Okay. Let me wrap with combining a few questions from audience members. Ron William asks, and nice to have you with us, Ron, what action should be taken to promote the use of vaccines once approved? And Susan Brown again asks, how can we assure that any vaccine program that is administered is done so equitably? And Olivia Hickman asks, how long do you think this pandemic will continue, which is certainly somewhat related, at least to the development of vaccines. So in closing, if we could both hear from you on some of these issues around vaccines, and if you want to include therapeutics as well, that's relevant too.
I will start by just saying that it'll be important that we allow the scientists to speak and take the leadership role here, because at the end of the day, the authority and the trust will come from having a clear, transparent communication that is science-driven, evidence-based. I also think that it'll be important to reckon with past structural barriers to equitable healthcare delivery during a time of COVID, when we are already confronting vaccine hesitancy. We're already confronting misinformation and mistrust. Communication is going to be important. The scientist has to be allowed to speak, and we have to address the mistrust and the misinformation problem that exists. Finally, it's really important that we not just focus on the COVID vaccine, but we understand the importance and the primacy that vaccine has played in advancing public health achievements in extending life expectancy, and in reducing preventable vaccine preventable deaths. We have to do something to communicate what the very important benefits of vaccines are and will be going forward.
I'll just add a few words, Michael. The vaccine story, in my mind, is actually one of the more positive elements of the response to COVID. We have a plethora of vaccine candidates, and I mean scores of candidates. We have a handful that have hit their marks in phase 1 studies of safety, phase 2 studies of dose and evoking a antibody response, and we're launched into several phase 3 studies to determine does the vaccine actually work? So Michelle's point about having the science be driven by scientists, interpreted by scientists, and judged by scientists is crucial for the next phase. I'd also commend the idea of early investment in capacity to manufacture the vaccines. This is going to be very important in building up the numbers of doses in unprecedented speed compared to what would have normally or in the past been considered the normal pace of vaccine production. But I do think the point that the questioners raise about actually administering the vaccine to protect people is going to have to overcome hesitancy on the one side, and equally, if not more important, move forward in an implementation plan that has the potential and promise to actually reach all of the eligible people in record time. And it's that final step of the administration strategy which will also call for unprecedented levels of planning and execution. And I would say thus far, that is the one area for vaccine progress that has not been as fully laid out as I would like to see, and I believe should be laid out in the coming weeks and months. If we have the vaccine that is demonstrated as safe and effective, we have the manufacturing capacity to produce millions of doses in record time, what then is our delivery system to get it actually administered to people? Remember, vaccine does not save lives. Immunization saves lives. We have to get the vaccine in the body to produce the protection that it can give us. So the vaccine story, on the one side, a great success to this point, and at the same time, a big challenge for the final mile of achievement.
Okay, well, that's a good way to close. I want to thank you both so much for participating in this. I think we and our audience learned a great deal from these two distinguished leaders in the space, dealing with a range of highly complex, tragic, difficult, but very important issues to resolve. So this is what we're all about, and bringing these ideas to the forefront with this forum. And so today was a great session. I want to apologize for the lateness and the fact that my video wasn't working. Maybe that made it better, who knows. But in any case, you got to hear from these great experts. So Harvey and Michelle, thank you so much, and we look forward to seeing the rest of you at our next session next month. Talk to you soon.
Thank you,
again.
Michael.
Thank you,
And thank you,
Michael.
Michelle.
Thank you, Harvey.